Professor Jean-Pierre Gerard, it's lovely to see you again. We first met on the Protocol Review Committee of the EORTC 20-something years ago. We're still both passionate about randomized clinical trials, I gather.
Yes, sure, because we are passionate for evidence-based medicine, and randomized trial is the best methodology to have evidence.
And here at this really lovely meeting on colorectal cancer in Nice.
And there was a special meeting for this randomized trial, and I would quote 4 of them, which I think really bring some solid evidence. First, the Dutch TME trial and the British CRO7 trial, both of them asking the question, do we need pre-op radiotherapy before surgery? Yeah. And if we look at the TME trial now, they have 10 years follow-up. And after 10 years follow-up, it is clear that even with a good TME, pre-op radiotherapy 5x5 reduce the risk of local relapse from, let's say, 11% to 6% at 10 years. So I think that's very strong evidence.
Very good.
Unfortunately, no impact on survival, even though if you look at specific cancer survival, you may have a small benefit, but for me, it is not strong evidence. And we get exactly the same result with a different methodology from the British CRO7 trial, where obviously when you do pre-op 5x5 to all the patients, you have a better local control than when you do selective post-op chemoradiotherapy. So for me, it is evidence that pre-op is better. That's the first point.
State of the art.
Yes, state of the art.
Next point.
Next point is the STAR trial and the ACCORD-12 trial. Both of these trials think that chemoradiotherapy is more efficient in T3, T4 than radiotherapy alone because of the EORTC trial and the FFCD trial. And those 2 trials try to upgrade and optimize the pre-op chemoradiotherapy. The STAR trial compare pre-op with 5-FU versus the same thing plus oxaliplatin. And the results are quite surprising because everybody was expecting that oxaliplatin will improve the sterilization rate. And they get 16% and 16% in both arms.
Wow.
So, to my surprise, oxaliplatin is not a good radiosensitizer, adding anything to radiotherapy and 5-FU. But on the other side, also, oxaliplatin is increasing the toxicity because the grade 3 toxicity and mainly diarrhea was 24% versus 8%.
Clear cut.
So the message is don't use oxaliplatin with concomitant 5-FU radiotherapy. And the ACCORD-12 trial, French trial, versus Italian trial, was the same patient, and they were using the same kind of oxaliplatin added to Xeloda, which is like 5-FU,
slow release, yes.
And they add dose radiotherapy escalation from 45 to 50 gray in the same duration of 5 weeks, which is biologically an increase of 15%. Okay. And in this trial, we found the same rate of toxicity like in the Italian trial, 24%, which was related to the oxaliplatin. But at the difference of the Italian trial, we found that the rate of sterilization, which was 13% in the 45 gray arm, was 19% in the 50 gray. So there is clearly a dose radiation escalation effect. And Xeloda can be, I think, looked at as equivalent at 5-FU. And in France, at least, this trial, the STAR trial, the Italian trial, the Dutch trial, and the British trial, everybody agreed that we should give it pre-op, that pre-op chemoradiotherapy is the best, and that the standard regimen for the present time should be 50 gray, 5 weeks, 2 gray per fraction, and capecitabine without oxaliplatin. We call it CAP50 regimen. So this is becoming the randomized trial, the standard. And the second point, which was for me very interesting, was a keynote lecture of Jean-Pierre, because he looked at the Eurocare statistical data from the cancer registries. And this is real life, because randomized trial is
1%
experience.
Yeah, sure.
But when you look at the whole picture of Europe, you find big difference in cancer survival rate, maybe 10% of difference in the best result and the country with less good results. And we can find that in some countries they never use pre-op radiochemotherapy. So it was interesting on one side to have the evidence from experimental randomized trial and to see that despite this evidence, to implement the best practice in the country is not always easy, and there is wide variation between countries.
So we have a major educational challenge.
You have this major education trial.
And the Cancer TV will do our very best to get your message out